we'll go over to the next topic. Dr. Abhinav is there with us now.
Thank you, Dr. Das. At the outset, I would thank Dr. Kapoor.
Yeah, Dr. Abhinav, let me introduce you.
Yeah.
So you are an alumnus of SGPGI. You did your DM in gastroenterology there when we were there.
Yeah.
And you are presently a faculty and consultant in the CK Birla Hospital in Jaipur.
Yes.
Yes. So you would be speaking about about the topic of association of colorectal of malignancy with ulcerative colitis, which is a very burning issue, and still we are undecided at certain points regarding the management. So we look forward to see your talk.
Thanks for kind introduction, Dr. Das. So this is, as you already said, this is a very important topic, and certain things are not yet decided. So first of all, let us understand whether this is the same disease we are talking about as sporadic colorectal cancer, or this is a different disease entity. So this is the difference between sporadic colorectal cancer and colorectal cancer in the setting of ulcerative colitis. In ulcerative colitis, mucinous and signet cell variety are found more often, and the pathogenesis is slightly different. Means in sporadic colorectal cancer, adenoma carcinoma sequence we all know with the loss of function of APC gene. While here in ulcerative colitis, chronic inflammation leads to dysplasia, and dysplasia leads to cancer. So the pathways and signaling pathways and mutations and timing of mutation, they are different. So probably this is a slightly different disease as compared to sporadic colorectal cancer. So to start with the recent case I encountered last week only, the lady has been on irregular follow-up. So this lady had a left-sided ulcerative colitis diagnosed way back in 2005, almost 18 years from now, and received multiple courses of steroid initially. Then later on, she developed diabetes, so she refrained from the steroid, and she had relapsed. So she landed up with a stool frequency of 7 to 8 per day, no blood. But her last colonoscopy was done in 2015. So last 8 years almost, no colonoscopy or screening has been done, despite the disease being of duration of 18 years, 18 long years. And last colonoscopy, it was grade 3 ulcerative colitis. Incidentally, her grandmother also had chronic diarrhea, which was never investigated. We don't know what was the cause. So we advised her scopy, but she was very averse to scopy, so didn't go for it. And she was also irregular on treatment. Every time we basically used to advise colonoscopy, she never agreed. Even sigmoidoscopy, she would refrain from. And she has continuous disease activity in the form of 8 to 10 stool per day, though blood was not there. In between, she stopped treatment altogether and switched to Ayurvedic treatment. So patient was not very compliant. Now, last week only she landed up with intestinal obstruction, gross air fluid level, pain, vomiting, and all those symptoms of obstruction. So we evaluated, and she was found to have a thickening in ascending colon cecum area with intestinal obstruction, obviously, and with the heterogeneous kind of opacity in the terminal ileum, suggestive some vegetative material probably was there. This time she agreed for colonoscopy, and we found a stricture at ascending colon cecum junction, which was a passable stricture. The mucosa overlaying is not typical of malignancy here because it is smooth glistening mucosa. The lining of stricture had a deep ulcer, and we carefully negotiated scope without any resistance. In cecum, there were moon crater-like of deep ulcers, which actually we usually see in CMV superinfection. And in terminal ileum, there was a phytobazole, which was impacting the terminal ileum and was the cause of obstruction, not the stricture per se. Now, sir, we sent the biopsy, and surprising biopsy came out as a well-differentiated carcinoma, though endoscopic appearance didn't look like a malignancy. So this is to summarize. This lady has ulcerative colitis for last 18 years, which is left-sided to begin with, poorly controlled. She was on irregular treatment. In between, stopped treatment. Follow-up was also irregular. She was averse to endoscopies. There was no surveillance colonoscopy despite 18 years of disease. She has had family history of chronic diarrhea in first degree relative, that is mother, which was not investigated, and she develops colorectal cancer. Now, so this is a very old study, 2001, got published in Gut 2001. This is a meta-analysis. And what is the risk of malignancy in colorectal cancer? This graph clearly illustrates that as duration increases, duration of disease, cumulative risk increases. 2%, 8%, 19%, 10 year, 20 year, and 30 years. The risk is dependent on basically duration of the disease. Now, what are the risk factors for colorectal cancer and ulcerative colitis? So this elegant study, very old one, NEJM 1990, this study has approximately 13,000 patients from Swedish registry. And what they looked at was age at diagnosis and extent of involvement. And as we can see in the boxes and the arrow, the pancolitis is associated more with colorectal cancer than proctitis and left-sided colitis. And as earlier the age, the more is the risk of the colorectal cancer. So this study, the conclusion was risk of this meta-analysis conclusion was the risk of colorectal cancer is higher with young age at diagnosis and presence of pancolitis rather than left-sided colitis. Now, this study basically again look at cumulative incidence of CRC with duration of disease, and you can see the plot there on the right side that as time from the diagnosis increases, the frequency again goes up. So cumulative, the figures are different here because we are dealing with Australian population here, but again, this study is listed that longer the duration of disease, higher is the risk of the colorectal cancer. So colorectal cancer risk is dependent upon duration of the disease, very well illustrated here in a different basically population cohort. Now, this study basically looked at another risk factor, presence or absence of primary sclerosing cholangitis. So on right side there is Kaplan-Meier curve. The dark lines are relates to those patients who have ulcerative colitis but no PSC, and gray line down there is PSC with ulcerative colitis. So presence of PSC increases risk of colorectal cancer from 2.9 to 5.8%. So presence of PSC doubles the risk of colorectal cancer. So PSC is a risk factor. Now, gender differences. This is data from Hong Kong. There approximately 7.5 lakh subjects. From them this data was drawn. And risk of colorectal cancer again is dependent on gender differences. Females are protected, possibly because of estrogen. So CRC you see is less common in females. Now this is another study, basically fairly large number of cohort and IBD with family history and without family history. So if there is a family history of colorectal cancer, IBD patient have higher risk of colorectal cancer, and this is to the tune of 8-fold risk. So family history of IBD, there are chances of CRC and UC patient 8-fold increase. Now, this is a very important concept recently published in Gut 2019, cumulative inflammatory burden. So what is cumulative inflammatory burden? Means what over last couple of years, what has been the inflammatory burden. So they calculated inflammatory score at macroscopic examination and microscopic examination both, and then between the different intervals multiplied by time of interval. So you can see the bar diagrams 2004, 2006, 2008. So these are timings of surveillance, and the score is calculated with the formula given above, and total cumulative burden is calculated, and then they basically looked at whether the risk of colorectal cancer is associated with cumulative inflammatory burden. So this Kaplan-Meier plot, you can see as cumulative burden increases, risk of colon carcinoma goes up. Now, they also this analysis also show that this is not related to one-time severity or maximum severity in last colonoscopy, but this is persistent of inflammation. Persistent of inflammation will lead to colorectal cancer. So risk of development of colorectal cancer is strongly associated with cumulative inflammatory burden rather than dis- disease duration simply, or rather than simply duration of severity of inflammation in last colonoscopy. So this is like we don't have to see the snapshot. We have to see whole video, the complete duration of disease, how much inflammation has been there in the colon, and that is associated with risk of colorectal cancer. So coming back to the lady we just encountered, she has long-standing disease for 18 years, which is poorly controlled, means higher cumulative inflammatory burden. She has been irregular on treatment, no surveillance colonoscopy, and probably her mother might also have had ulcerative colitis, which was never diagnosed. So these are the risk factor. So uh, these all these parameters make her to fall in the high risk category for colorectal cancer, hence she developed cancer. Now coming to surveillance strategies, then obviously we know that surveillance is being done by colonoscopy. So what are the guidelines? So these are different guidelines from different societies and associations. The gist of these guidelines is that first screening colonoscopy, it has to be done at least first colonoscopy has to be done 8 to 10 years after the onset of symptoms, and further colonoscopy based on risk stratification. So patients are stratified in high risk, intermediate risk, and low risk category. In high risk, screening is recommended annually, intermediate every 2 to 3 years, and low risk every 5 years. So what is high risk? High risk basically are patients with IBD who have first degree relative who had early colorectal cancer. That means less than 50 years. That qualifies for high risk. Intermediate, first degree relative with CRC, but after 50 years of age. IBD with dysplasia, high risk. Extensive colitis with severe inflammation, high risk. And presence of primary sclerosing cholangitis is high risk. So these patients have to be screened annually. Other than more than 50-year first degree relative with colorectal cancer, another criteria which has been outlined in ECO guideline is moderate active inflammation that puts patient into intermediate risk, and these patients would be screened every 2 to 3 years. Low risk are patient or those patients who either have left-sided colitis and with minimal inflammation or no inflammation, who well-controlled disease in remission and no dysplasia. So every 5 years, these patients will be screened. So first colonoscopy and then the, the repeat colonoscopy intervals, very well outlined by these guidelines. The problem is adherence. And this elegant study, 2002, recent one only, elementary pharmacotherapeutics, they looked at adherence to endoscopic surveillance. Means we are advising them colonoscopy, how many of them are turning up? So fairly good number of patients, around 1,000 patients, 700 with ulcerative colitis, and this is the non-compliance rate. Means either they didn't turn up for colonoscopy at all, or they delayed their screening colonoscopy. It was very well seen from this study that low risk group non-compliance rate was 13%, but in high risk group almost 40% patients didn't turn up. Means higher the risk, more is the non-adherence to compliance. So this is important issue here. And what reasons they cited for non-compliance? One was transportation, non-availability of finances or non-arrangement of finances. Some patient, they felt that colonoscopy will be procedure with lot of discomfort, and sometimes bowel, they didn't want to do bowel preparation. So non-compliance is issue. Now, how to do surveillance? So traditionally we have been doing routine colonoscopy, which is called white light colonoscopy. But now later on, various modalities have come up to improve the yield of dysplasia or colorectal cancer detection in colonoscopy, that is chromoendoscopy. Then newer technology, narrowband imaging from Olympus, Fusionon from FICE from Fusionon, and iScan for Pente. This is called optical chromoendoscopy. And newer modalities are coming up, not in very much use, but probably modalities of future: autofluorescence, confocal laser microendoscopy, endocytoscopy, and few. So we are doing white light endoscopy. This kind of lesion is found on the background of just little bit erythematous mucosa. What to do? To biopsy or not to biopsy? So this is always the confusion. White light endoscopy miss rate is 2 to 6% of the colorectal cancer, which is not a small number. Now, somebody asked this question on Quora, okay, what is function of staining in light microscope? Well, you can see on the left side, unstained tissue, we can't identify anything. And to study the tissue in detail, we need staining. Same way, if we put stains on this lesion, which was non-descript on white light endoscopy, the lesion stands out very, very well. So we can take targeted biopsy, and usually the stains are methylene blue or usual iodine. So these kind of stains. So what is the impact of staining? On left side, the finding which can be easily missed as a areal focal erythema, we can see that we can see a line of demarcation after methylene blue, and this lesion is very well standing out. So the miss rate is can be brought down. And this basically turned out to be high grade insight with the colonic neoplasia, missing which it might have very deleterious effect to the patient. Now we know that everybody has unique fingertip mark, and it has been incorporated in Aadhaar card also in India. So likewise, colon also have pit pattern, which is unique to the type of pathology. And with change in pathology, the pit pattern they get modified, or they are different. So the Kudos classification classifies them into non-neoplastic pattern, neoplastic but non-invasive pattern, and invasive pattern. So on chromoendoscope, we can find out, and this is the meta-analysis. This is a very accurate diagnostic method by doing chromoendoscopy. By studying Kudos pit pattern, neoplastic lesions can be identified with a lot of accuracy. Now, this is a comparison between white light endoscopy and chromoendoscopy, and chromoendoscopy improves detection rate of dysplasia. But if you have high definition endoscope, then basically it was found that high definition endoscope basically is equal to chromoendoscopy. So improvement in endoscope can also improve detection rate. This study very well outlines that. Now, problem with chromoendoscopy is it's cumbersome. It requires special stents, and it requires a special spray catheter. So nowadays, the endoscope itself has an ability called NBI, where we can filter out the red spectrum, and we can use pure blue and green light to improve the visibility of vessel. And as we know that as tumor basically develops, it requires blood vessels to feed it, and morphology of blood vessel changes. So on a click of button, we can do optical chromoendoscopy using NBA endoscope. No stain is required, no special catheter is required. It saves time. Now on NBI, the lesion on left, which is very nondescript on white light endoscopy and which can be easily missed, stand out very well in NBA mode without any chromo endoscope, without need of any special stain. And people have extensively studied, most of the study are there from Japan, and they've studied very well that what are capillary pattern associated with neoplasia and what are capillary pattern which are associated with adenoma. And they've been classified into nice classification, JNet classification, and it has been very well established fact that with these patterns we can identify adenoma and we can identify invasive cancer. Now, so this lesion of sigmoid colon 6 millimeter, which was almost inconspicuous on white light, is basically low grade adenoma with low grade dysplasia on NBI imaging, and we can also detect cancers. So these are the type of polyp, hyperplastic adenomatous malignant polyp can be very well categorized using NBI scope and using the various kind of classifications. Now, what is the yield of NBI? So this is a meta-analysis of 13 study. Accuracy of NBI in diagnosis deep submucosal and invasion is sensitivity 77% and specificity 98%. So very good modality, and this is very quick one also. Now, in ulcerative colitis, image-enhanced endoscopy yields better result than white light endoscopy. And if you high definition endoscope, that is even better. NBI saves your time. And these are the studies to substantiate this fact. Now, coming to tissue acquisition, there are two protocols. The age-old random biopsies, every 10 centimeter, total 33 biopsies are taken, and targeted biopsy when we biopsy only suspicious area. ECO consensus in 2017, it recommended chromoendoscopy with targeted biopsy. So it saves time. And multi-center randomized control trial comparing these two biopsy protocols, it suggested that if you do targeted biopsy, detection rates are similar. So no need of biopsy every 10 centimeter, no need to take 33 biopsy. If you use chromoendoscope, if you use NBI scope, if you detect the lesion and do targeted biopsy, yield later similar, and the targeted biopsy less time consuming. So nowadays, the NBI means high definition scope, NBI scope and targeted biopsy is the way to go. Now, this is coming a modality, not very well available. This is basically just to highlight that what might come up in future. These are endocytoscope, ultra high resolution endoscope with 250x zoom. Our routine microscope is 400 zoom. The here zoom is 250x. So you can even see mitotic figure. You can see nucleus. You can see nucleus, and you can make a diagnosis there and then itself. So this is the thing which is coming up. So other than these modalities, ultra fancy things, the basic thing which are there are very important. Is bowel preparation has to be very good. If bowel preparation is not very good, then you won't be able to see anything, whatever modality you might use. And we have to spend proper time in examination. And there is data to substance this fact also that endoscopies whose withdrawal time was more than 6 minutes detected more polyp than those who finished endoscopy in less than 6 minutes. So spending time and good preparation are very important. Now, a word just to slide on basically chemo prevention can be prevented since we have seen that cumulative inflammatory burden, if it is high, then carcinoma chances are high. And inflammation adenoma carcinoma sequence, it is the pathogenesis of colorectal cancer in ulcerative colitis. So if we keep inflammation suppressed, so we will be obviating the risk of adenoma formation and carcinoma in ulcerative colitis. So 5-ASA has very strong inflammatory property through suppression of various inflammatory pathways. And in meta-analysis 13 study, 5-ASA proven to have strong protective effect against colorectal cancer. So 5-ASA should never be stopped. Now these are the studies which basically they have, this table summarizes various the various agents used in ulcerative colitis and their protective effect. 5-ASA, thiopurine, UDCA, and anti-TNF agent. So all of them they have protective effect against colorectal cancer. Means if you keep inflammation suppressed, colorectal cancer will not be there. And in ECHO recommendation 2017, ASA is for lifelong chemo prevention, but the compliance is issue, so we have to ensure the compliance. Thiopurine's problem of continuing thiopurine for long term is non-melanoma skin cancer and other cancers. So they have not been recommended per guidelines. But basically, if you are using them, if you are forced to use them, then you have to basically be watchful for development of other cancer. UDC has only been recommended only in primary sclerosing cholangitis associated IBD, but not for prevention of colorectal cancer in ulcerative colitis per se. And biologicals again concerned about adverse events are there. So 5-ASA recommended, other agents conditional. Now coming back to our patient, this lady has a left-sided ulcerative colitis. Then why the cancer occurred on the right side? So on this again, I looked at literature. There is enough data. This is systematic analysis, and approximately a significant proportion of left-sided colitis. Eventually, here in this study, follow-up was 9 years. So after that, end of 9 years, they go on to develop pancolitis. They evolve into pancolitis, and more so if they are basically unresponsive to 5-ASA or if there are ongoing inflammation, then they may progress to pancolitis. So this patient, when she was not very compliant and she was not on follow-up and she never had repeat scopies done, that time probably she might have evolved into pancolitis from left-sided colitis and hence colon cancer developed on right-sided colitis. So this is my last slide. Colorectal cancer in ulcerative colitis is different pathogenesis and sporadic CRC. We are dealing with slightly different disease. Risk factors are early age at diagnosis, longer duration disease, presence of pancolitis, family history, and coexisting PSC. The cumulative inflammatory burden is a involving concept. I feel this is a very good concept. High cumulative inflammatory burden is colorectal cancer. So we don't have to look at snapshot. We have to look at whole reel, how much inflammatory burden has been there. The screening for colorectal cancer dysplasia should begin 8 to 10 years after the diagnosis. Interval 5 years in low risk, annually high risk, and 2 to 3 years in intermediate risk. Thorough examination with white light endoscopy to detect target area, targeted biopsy. If we have image enhanced endoscopy, then the yield rates even better. And we have to keep inflammation suppressed to prevent ERC. Lifelong ASA should be advised to be patient with chemotherapy. Thank you.
Abhinav, that was a wonderful presentation.
Thank you, sir.
And so extensively dealt with, wonderfully described almost all the evidence tossed upon, and very nice messages coming out of it. Now, actually, it was a learning experience for me also. Uh, I have if I say for the for the students who have just entered into the GI surgery fraternity, can you give them a algorithm approach to the patient of ulcerative colitis where we find malignancy?
Uh,
First thing, please answer me. Once we diagnose malignancy, should we stop the immunosuppression if it's on?
the question is which malignancy you are talking about. If you are talking about other malignancy like colorectal, like skin cancer or bladder cancer or lymphoma, then obviously immunosuppression has to go.
Well, colonic.
Second, if a colorectal cancer has developed, then obviously you're going ahead with colectomy, and after that, the immunosuppression will not be required at all.
Okay. And colonic rectal malignancies without the setting of ulcerative colitis, we say they are different.
Yeah.
So is it same for ulcerative colitis, the colonic malignancy, the prognosis, the rectal malignancy, the treatment is different or same?
If it is run-of-the-mill adenocarcinoma, then obviously treatment is going to be the same. Only thing adds up here is ulcerative colitis. But if it is mucinous, if it is a signet cell variety, then obviously the tumor is going to behave differently and will tend to a more aggressive clinical course. So, but eventually the treatment would remain same. As you treat other cancers, it will also be the same colectomy or same resection you will have to do depending on the stage of the disease, and similar kind of follow-up you'll require.
Does CA holds good like any other colorectal cancer here?
I'm not sure because in Indian patients, CA is not that very well correlated. At least in our clinical practice, we don't see that it is, despite the colorectal cancer being there, CA tends to be normal here in Indian patients.
See, in the prognosis, vis-a-vis the stage per se, stage, if we compare the prognosis of colorectal malignancy in ulcerative colitis versus colorectal malignancy per se, the prognosis is different.
The problem with ulcerative colitis is a long debilitating disease, and the patient is usually nutritionally depleted, and surgical outcomes would be not that good as sporadic colorectal cancer, where patient is otherwise healthy. So these patients are hypoalbuminic, nutritionally depleted. They have chronic inflammatory state. They are anemic. So they will require more optimization to get a better surgical result.
And the genetic parameters or genetic studies same in both the situations?
Genetic pathways are different of both of the entities. Here, in the sporadic, you have adenoma carcinoma sequence, you have APC gene mutation, P53 gene mutation comes very late in that case, while here P53 gene mutation comes early, APC is late. So pathogenesis genetic wise, it's different here.
Regarding the treatment, as like seeing microsite RNA, microRNA instability and KRAS genes, are these do these hold good for colorectal malignancy in a setting of ulcerative colitis?
MSI, I'm not sure, but obviously the signaling pathway are different. KRAS gene mutation frequency are different, but MSI, I'm not sure.
Dr. Das, I may interrupt. We have a tradition to close exactly at 9. So we will have to kind of close. Before closing,
Yes.
I'll make an announcement. So, students, if you send me a mail at vkkapoor.india@gmail.com and write UC in the subject of the mail, so I'll send you the chapter on restorative proctocolectomy from my operative surgery textbook. So, with that, I would like to thank Dr. Das for chipping in at the last minute to moderate this session, to Dr. Francis Sochin from Singapore, Dr. Chetan Kantharia, and Dr. Abhinav.
Thank you,
Thank
sir.
you. Thank you very much. Thank you. Thank you, everyone.
Thank you,
Thank
sir.
you.
Thank you.
Bye.
Thank you,
Bye.
Dr.